Hello, Umesh.
Good morning. Good morning, everyone. Am I audible? Okay. A very good morning to all. We welcome all the delegates, offline and online delegates, for our skill enhancement workshop. We are very excited to have all of you here to develop new skills from our very skilled resource persons who are a part of the simulation lab. They will enhance your existing ones to a much higher level. So over the next few hours, you'll be provided with the tools and knowledge wherein you will take your skill to the next level. So we all welcome you to the skill enhancement workshop. Our goal is to provide a supportive and interactive learning environment that will help you achieve your full potential. I would also like to welcome our esteemed resource persons for today's workshop, Dr. Atik Harlapur, who will be demonstrating the skill on trauma care, cervical spine rehabilitation and log roll. He is assistant professor from the Department of Biochemistry, JNMC Belgaum. Also welcome Dr. Netravati Angadi, Associate Professor, Department of Pharmacology, who will be demonstrating optimizing intravenous drug administration, best practices and simulation training with mannequins. I also welcome Dr. Soumya Maste, Associate Professor, Department of Microbiology, who will be demonstrating clean hands are safe hands, that is about hand hygiene. I also welcome Dr. Sunil Vernekar, Professor, Department of Physiology, who will be demonstrating helping babies breathe. So with this brief remark, I welcome you all for the skill enhancement program. Thank you.
I would like to welcome our first speaker, Dr. Atik Rehman Harlapur. He is working as assistant professor in the Department of Biochemistry at Jawaharlal Nehru Medical College, Belgavi. He is a certified trainer of trainers in BLS by Jeevan Raksha. His co-presenters are postgraduates of Department of Biochemistry, Mr. Shrikant and Mr. Aditya Singh. He will be demonstrating cervical spine stabilization and log roll in trauma care. Over to you, sir.
Yes, very good morning to you all. Here I would like to call upon Shrikant, my postgraduate, and Aditya to help me demonstrate cervical spine stabilization and log roll in case of trauma patient. But before we go to cervical spine stabilization and log roll, we should understand that in any trauma case, we need to take care of the hemorrhage first. Yes, we need to take care of the hemorrhage first. So, in any emergency situation, when we look at, and especially if major trauma is involved, hemorrhage control becomes the first paramount, then airway and breathing. So, here in our skill lab of Kaher, we have this mannequin where we demonstrate multi-trauma. So, here on this patient, we have a fractured tibia with bleeding present. So, we are going to take care of the hemorrhage first. So, when we talk about control of hemorrhage, we can use a tourniquet, a very simple band which can be used. Now, placement of the tourniquet is 4 fingers above the lesions, but if you encounter one joint, then it has to be above the joint. So, since this is knee joint is coming, I am going to go above the joint and place the tourniquet. The tourniquet should be tight enough to decrease the bleeding and cut off the distal pulsations. If the distal pulsations are not cut, then it is a venous tourniquet and it is going to cause a compartment syndrome and will have much more trouble later than the bleeder which has come. First of all, bleeding won't stop. Second, there will be compartment syndrome. So you have to see to it that the distal pulsations stop. If you have a tourniquet, well and good. If you don't have a tourniquet, use a pressure dressing. Pressure dressing can be in a form of this particular dressing. You can just wound it round tightly such that the distal pulsations are blocked. Coming right here. Yes. If you don't have a pressure dressing, then any cloth which will not tear itself on pressure can be used. You can make it into a small proximal portion and long distal portion. Again, go to the place above the joint or 4 fingers above the lesion. The small portion will go in first, the long portion will come down and over it. And I will tie a tourniquet. I will tie the first knot with the smaller portion and tighten it. Then take a second knot, but I will not tighten it. Use something which is sturdy, a wooden rod, a steel rod, a spanner or a plastic pipe which will not bend or break under strain. I just pass it below that knot where I have made it and now start turning it as if I am trying to close a tap. So I will make the turn once or twice such that the distal pulsations are stopped. So this is in-field tourniquet. Now that I have stopped the distal pulsations, my job is to keep this tourniquet in place. So what I will do, I will take it beneath one portion, go above the other portion, below the knee, come up and now tie it to the small of the this way it will be held in place. Once I have tied it, I will mark the time and which this has been tied, and every 20 minutes release it a bit and re-tie it again. So I have taken care of the hemorrhage. The second part is to looking at the airway. Any road traffic accident, how do we know this is a road traffic accident? If I am coming here after some time and I don't know what has happened and the person is lying alone, look for any trauma on the head. Any trauma on the head, assume there is cervical spine injury. So how do we stabilize cervical spine injury whenever we are looking at? So the best thing to do is to use a cervical collar. A cervical collar can be used to stabilize the spine, but how do we put that? We'll be telling you. Or we can do manual inline stabilization. So I request Shrikant to show us the technique for manual. So what he's going to do is, he's going to take his hand like this. The fingers and the palm will go under the shoulder blade. The thumb will be on the trapezius muscle, gripping it on both the sides. He will be holding the neck of the individual between his two arms. So he will be going in position like this, and you can see that his thumbs are up here, his legs, the fingers are on the shoulder blade, and both his hands are now stabilizing the neck. And now he will be lifting the neck in line with the back without flexing the cervical spine. This is the key element of stabilization of the cervical spine, which is going to give me some space to put this cervical collar without flexing the spine. Yes, Shrikant, go ahead. You can see that the spine was lifted and without moving the cervical spine. Now that I have put the cervical collar, when I am trying to fix the cervical collar, what will Shrikant do is, he will try to give the thrust, what we call it jaw thrust, on the malar eminence of the individual, such that the head is fixed on the hard surface, while I manipulate and put it so that no movement of cervical spine is happening at that. I am assuming that this patient is breathing properly, his pulse is above 90 systolic. So the moment the radial pulsations are felt, it is assumed that it is at 90 systolic. So any trauma care, what we do is we go for something called as preemptive hypotension. We don't increase the blood pressure to normal, because what has happened, he has multiple traumas, there are clots which are now blocking all the bleeding which is happening. If I increase the pressure outside the hospital, that clots may be dislodged and the bleeding may be further profuse. So I am going to keep the pressure at 90 systolic. However, there is only one exception for this. In case of head injury, we need to have a blood pressure of 110/70 in order to maintain the perfusion, maintain the cerebral perfusion. So in head injury, we go for 110/70. If there is no head injury, we go for preemptive hypotension. Now, next is how we move this patient. We have controlled the bleeding, the patient is breathing properly, blood pressure is at 110/70. The other wounds need to be dressed. All we can do is just give cover dressing, no need to give any dressing per se, no need to reduce any fracture in the field. We can take it up in the hospital later. Now, when the help arrives, we do a maneuver called as log roll. So log roll is a maneuver in which a patient with multiple traumas is moved without flexing the spine. So the entire spine, may it be lumbar, thoracic or cervical, we are not going to flex any of this spine. Without flexing the spine, we have to move this patient. So this is what we are going to do. For that movement, we need 4 people minimum. First, we'll have Shrikant who is going to stabilize the cervical spine, even though cervical collar had been put. So please stabilize the spine. So I'm the next person. I want Aditya to come forward and Baswaraj to come forward to help me out. Now this is very important, how we place our hand on the individual when we are actually doing the log roll. So the first person who is standing to the head end will keep the hand on the shoulder and the upper back, and the second hand will go below the hip region. Now the second person who is coming will pass the hand below my hand and grip the hip This is the first. You can see that his hand is coming under me, and then his second hand will go below the knee. Yes. The third person who is there will take care of the hand at the knee, and his other hand, watch the other hand go below. His other hand, the last person should have that hand below. So this is how we do it. So this should be done whenever we are ready to be shifting or log rolling the patient. So we'll have a hardboard ready which will be brought in the ambulance. The moment it is brought, he has to be moved on that. Now remember, log roll is essential so as to we don't flex the spine. The entire spine should not be flexed. So someone has to take the lead, so I will take the lead here and call out 1, 2, 3. At the count of 3, we all will move the patient. Shrikant will see to it that the cervical spine does not flex. At the same time, me, Aditya and Basavraj will see to it that the other thoracic and lumbar spine is not flexed. So we are going to go 1, 2, 3. The board is brought in. The board is placed vertical against the back of the individual. We are not going to slide it. While we are putting the patient back down, okay, Manjunath and Ansari are going to press this board down and towards us. Okay, so 1, 2, 3. So you can see that with minimum motion, this particular individual was brought onto the board without flexing the knee joint. However, the primary assessment when we did, we saw there was a bleeding. The primary assessment we did, we assumed there is a cervical spine injury. We stabilized the cervical spine. Now once the patient is there, if time permits, you can do secondary survey to see what has happened to the bleeding which is there. Are the dressings which have been put are in place? Again, you can check the blood pressure, you can check the respiration, you can check the breath sounds. If everything is stable, then we can lock. We need to stabilize the individual. We have put cervical collar, but along with cervical collar, we can use sandbags on either side of the neck to stabilize. If you don't have sandbags, and if the ambulance is well equipped, it will come with another stabilizer which can go the same way under, and it will lock the head of the individual during transport. The head will come in between here and will lock cable. These straps are there which will keep the head in place so that any lateral movement during transport is avoided in this particular individual. So once I am satisfied that the patient is now fit for travel, we can just move the patient away. Yes, so this is what we do in case of multiple trauma patients. So always remember, in case of multiple injuries of trauma, in case of road traffic accident, crush injuries or any other type of injuries, controlling the hemorrhage becomes the first and paramount important, along with putting 18 gauge large bore needle on both the sides. 2 we need, so depending upon which side is available for us. If there is only trauma to the legs and both the hands are available, we can go ahead and put the large bore needle to take care of the circulation also and to administer any drug. Yes, any questions which you could think of?
Participants also, if you have any questions, you can put it in the chat box or please raise your hand so that we can unmute you and then directly you can ask. No, sir. Very nice.
Any questions?
Thank you, Dr. Faisal. Any other person is having any question?
Physical.
If there are no
Yes.
if there are no questions, we will move on to our next session.
Yeah, Ansari, wait for 1 minute. We will see if they're having any questions. Sir was demonstrating something with the physical
Yes, any
registered delegate.
questions you have in your mind? Yes.
Can you speak little loudly, Dr. Basavraj?
In road traffic accidents, there will be air blockage of that. I mean, instead of managing the hemorrhage, if there is a air block, what should we do from the spot?
Now, what happens is in any trauma case, okay, let's say for example, we will go with your assumption that I'll take care of the airway first. Let us assume when I'm managing the airway, there is a leak. There is a leak and it is bleeding. Alright, and any bleeder, let it be venous, let it be arterial, you have only minutes to save the patient. You have only minutes. So that is why hemorrhage becomes first in trauma. Hemorrhage becomes first, then becomes airway. Second is airway. In other emergency situation, it is the circulation which takes the first prominent. Like for example, in case of cardiac arrest, we go for chest compression first, then airway. But here in hemorrhage, we go, in case of trauma, we go for hemorrhage first, control the hemorrhage first, and then you can come to the airway. Now, the problem with the airway, I will tell you practically, in road traffic accident, it will be either hemothorax, it will be pneumothorax, or it will be tension pneumothorax. It will be either of these two. It requires intervention. It requires intervention, and that intervention takes time. So we will prevent the leak first, stop the leak first, then we will take care of the airway, because the next is airway. Understand? So here we need a team. One person cannot do this job. We need a person who will tell you manage the hemorrhage, I will manage the airway. So it is the team who will have to work, not one person. So you have to have a team, otherwise it will be difficult. But yes, hemorrhage comes first, then airway.
Any other questions from the participants? You can unmute yourself and have a little dialogue also if you want to have with the Atik sir. If no more questions, can we go to the next session? At least if we'll see the thumbs up or something, we'll come to know the people are there. Okay, so in between, meanwhile, we are shifting to the next session.
Okay. Thank you, sir, very much for the very knowledgeable session on trauma care and cervical spine stabilization.
Thank
Now,
you.
now we will move on to the next session. Give us few minutes as we make arrangements for the next session.
Yeah. Till we make the arrangement for the next session, I would like to take this opportunity to invite you all for the Epicon 2025. So this time Epicon 2025 will be hosted at JNMC, Jain Medical College, Belagavi, and we welcome you all. And we'll be opening the registration slots very soon, maybe first week of April, and we will love to host you here, and we welcome you here in the month of October. It's 9th, 10th, 8th to 12th October. 8th, 9th is pre-conference workshop, and 10th, 11th, 12th is the conference dates. Yeah. So now we'll move to the second session. Yes. So.
Now I'm going to call next speaker, Dr. Netravati Kavi, Associate Professor, Department of Pharmacology in KLE Jawaharlal Nehru Medical College. She has more than 20 indexed publication, and her site of interest is inflammation, wound healing studies, diabetes, clinical research and medical education. And she's having a 15 years experience. Now I am going to hand over the mic to the Dr. Netravati ma'am.
Yeah, very good morning to everyone. Welcome to today's session on the optimizing intravenous administration, the best practices and simulation training using the mannequins. And I thank the organizers for giving me this opportunity to share how to put an IV line with all of you. So basically, whether this IV cannulation is one of the most fundamental and most widely used procedures in healthcare, be it for administering the fluids or medications or taking the blood sample, IV access, it plays a crucial role in patient care. So through this session, we are going to provide you with the knowledge, a brief knowledge on what is the IV route of administration, and then hands-on experience which is necessary to perform this procedure effectively and safely. So routes of administration, so we have a lot of routes through which the drug can be given to the patient or the other people. So in sometimes the drugs not only mean that are given to the patients, even vaccines also are also considered as drugs which will modify the physiological systems in the body. So the most drugs can be administered by various routes, as I told. So the selection of an appropriate route in a given situation mainly depends upon both the drug as well as patient related factors. So various factors needs to be considered while choosing what is the route of drug administration that you are going to choose when giving to the patient. So basically, we divide the routes of drug administration into systemic routes and the local routes. So in systemic route of drug administration, we have enteral routes and parenteral. Enteral means which are the route of administration where the drug is given into the enteric system, that is through the GIT. So it could be either in the form of oral route of administration or sublingual route of administration, or it could be through the rectal route of administration. Parenteral is, it is apart from or apart from the entering into the GIT or enteric system, where it could be through the inhalational route, transdermal route, or it could be various through different form of injections, either in the form of intravenous route of drug administration, intramuscular, subcutaneous, or it could be intradermal, intraarticular, or intraarterial. So under local routes of drug administration, we have topical routes, intranasal routes, mucosal, or through throat, vaginal, or ear or eye drops in the form of eye drops. So here in this model, the objectives of today's module are introduction of an IV route of administration. Mainly, we are going to talk about how an IV route is being secured in patient, selecting of an appropriate vein for the IV cannulation, insertion of the cannula safely and effectively into the vein, and then securing the cannula properly and ensuring the patient safety, recognizing the potential complications and responding quickly to the patient in case of the complications which can come when we are giving or putting an IV cannulation or giving the drugs through intravenous routes. So the types of injections, as I told us, it could be the subcutaneous injection, intramuscular, intravenous, intraosseous, or intradermal. In subcutaneous injection, where the drug is delivered into a layer of fat or in a subcutaneous tissue that is just underneath the skin. In case of intramuscular injection, here the drug is delivered into the muscle, whereas in case of intravenous injection, the drug is delivered directly into the vein. And in case of intraosseous injection, the drug is delivered into the bone marrow. Intradermal injection, the medicines are delivered in between the layers of the skin. So you can see the differences in the different injection techniques. So in the intramuscular, and the angle of administration of these drug or giving an injection also differs in all of these techniques. In case of intramuscular, the angle of administration is at 90 degree, where the injection is given at an angle of 90 degree, and the injection is injected directly into the muscle. Whereas in case of subcutaneous, the angle of insertion of the injection is at 45 degrees, and the drug is injected into the subcutaneous or the loose tissue of fat just beneath the skin. So that is why it's called a subcutaneous injection or route of administration. In case of intravenous, where we are giving the drugs or the medications directly into the veins, but here the angle of administration is at an angle of 25 into 30 degrees. And in case of intradermal, where the drug is injected into the different layers of the skin, so that's why it's called as intradermal, and the angle of insertion of the needle is 10 to 15 degree. So coming to the IV route of drug administration, why it's called intravenous is, it is a term that means into the vein. That's why it's called as intravenous. So when we call it as an intravenous administration is when a needle is inserted into a vein and the medication is administered to that needle, then it is called as intravenous route of drug administration. So different veins are being selected throughout the body for giving an intravenous route of drug administration. The most common sites for IV drug administration includes the veins that are common or visible in the hands, that is in the forearm and the hand, and then in the legs. So sites of administration in the hand include antecubital vein or the median cubital vein, veins on the dorsum of the forearm and the hands, and leg veins or the scalp veins. So in the veins of the dorsum of the forearm or the hand, we can choose either cephalic vein, basilic vein, or even a dorsal venous arch can be chosen. So this again depends upon the patient's condition. So based on the patient's accessibility and the visibility of the vein, you can choose any one of these veins for easy administration of the IV cannulation. So leg veins. So veins of the foot, like great saphenous vein, lesser saphenous vein, or dorsal venous arch can be chosen, or even a lateral marginal veins. Or in case of certain complications, you can also choose, if it is the other veins are not visible, you can also choose the medial marginal veins. In pediatric population, the most common veins which we choose for IV cannulation and giving IV route of drug administration are the veins in the hand and the legs. In certain conditions, like in pediatric population, if the veins are collapsed and if they are not visible, then you can go for the veins visible on the scalp, that is supratrochlear or supraorbital or posterior auricular or superficial temporal. This is the last resort, but the most commonly used veins or the sites are the veins which I showed you in the forearm and the hand and the leg veins. So this IV intravenous injection can be given in different forms. It could be in the form of bolus injection, or it could be in the form of an infusion, or it could be as a volume replacement. So what do you mean by bolus injection? Where in case of bolus injection, large dose of the drug is administered as a single IV injection. Like when we give an injection furosemide or lignocaine, where at a time we are giving a large volume of the drug as it is injection. In case of infusion, where there is a continuous flow is maintained such that a small constant amount of the drug reaches the body over a period of time. So you must have seen in case of emergencies or patients who are admitted in the ICU which require continuous drug administration are infused with IV infusion, or they are given the drugs in the form of IV infusion like dopamine or metronidazole injection, where the drug you can titrate the dose of the drug, and also you can monitor what is the amount of the drug that is flowing to the patient. So every minute you can adjust the drip set, what is the dose of the drug that has to be delivered by the patient can be accurately set in case of infusion. The other form of IV injection is volume replacement, where when we want to give a large volume of the fluid, then it has to be given as a volume replacement. Like in cases of severe dehydration, or whenever during the surgery there is an intraoperative blood loss, or due to trauma patient has come with severe blood loss, where we have to replace the volume. So either in the form of giving normal saline or 5% dextrose solution, or even a blood transfusion. So that time again IV route is preferred. So where larger volume like 500 ml, 1 liter, or even up to 2 to 3 liters of volume in case of severe dehydration, or in patient who has got severe blood loss, volume replacement can be done in larger volumes. So these are the examples. So in case of bolus injection, a single dose where a large volume of the drug is given as a single dose of the drug. In case of infusion, so we can, as I said, we can set what is the rate, what is the volume, and what is the dose of the drug per minute, how much it is administered can be monitored, and it can be delivered to the patient. As volume replacement, as I showed you in case of severe dehydration or something, where we can give larger volume of the drug can be replaced to the patient. Why do we choose? When I showed you the lot of varieties of, or various routes of drug administration are there, when do we choose, or why do we choose intravenous route of drug infusion? The first thing is the onset of action with intravenous route is rapid. It immediately produces the action. Whereas in case of other routes like oral route or intramuscular or subcutaneous route, it takes some time for the drug to act, because ultimately the drug has to be absorbed, and then it has to reach the systemic circulation to produce its action. Whereas in case of intravenous route, because we are giving the drug directly into the systemic circulation, the onset of action is rapid. Because the onset of action is rapid, we can use them in case of emergencies. So where we require the immediate action, so intravenous route can be a life-saving route in case of emergencies, where the onset of action of the rapid could be rapid. So onset of action could be rapid. And it has bioavailability of 100%. Bioavailability is the percentage of the active drug that is available for action. So because it is not going and reaching the entrance system, or it is not coming in contact with any of the metabolizing enzymes, directly it is entering into the systemic circulation. So the amount of active drug available is 100%. And as I told you, the advantages, larger volumes can be infused compared to that of intramuscular and subcutaneous, where we cannot give larger volumes, whereas in intravenous we can give larger volumes. And as I said, the doses of drugs can be accurately titrated whenever necessary. So you can, if it required, you can increase the dosage, and if at all, if you want to stop or decrease the dose, you can reduce the amount of the drug that is reaching the patient. And one more advantage is it can be used in unconscious and uncooperative patients, where patients' cooperation is not required. And in case of unconscious patients, this is the most sought out form of route of drug administration. But it comes with certain disadvantages as well. So whenever giving an intravenous, or whenever you are giving an IV access, drugs through IV access, strict aseptic conditions are required, because otherwise it can result in infections. So, and another disadvantage is painful, and self-administration is not possible. So because the self-administration, it requires assistance, and somebody has to give the IV drugs. So it can be used only when the patient is admitted in the hospital settings. Okay, or either in the OPD settings or in the inpatient settings. It cannot be taken at home. So this is the only route of administration which is given in the hospital settings and not at home. So otherwise, mostly commonly used route of drug administration at home is oral route, followed by others. Like subcutaneous also, you can train the patient to take the subcutaneous injections, but it is not possible. Some assistance is required in case of IV. So this is only given when the patient is admitted in the hospital settings. And only aqueous solutions can be given. Even though some of the IV injections are available in powder forms, we have to make a solution of it before administering it to the patient. And adverse reactions are more likely to occur. Whereas this is in comparison to, although the reactions are less, but in comparison to the oral route or other routes, they are the safest. Okay, they do not come up with any adverse reactions, particularly because of route of administrations, not because of the drugs per se. So here, with respect to routes, adverse reactions can occur because of intravenous, because it has certain harm. One is it can cause pain. The other one is because while if you do not maintain strict aseptic precautions, then it can result in infections in the patient, or if the drug extravasates to other tissues, then also it can result in complications. I'll show you what are the complications associated with intravenous route of drug administrations. And the risk of anaphylaxis is also maximum with this route of administration. So now let's see. So with the brief background of what is intravenous route of drug administration, let's see how do we proceed with what are the requirements to put an IV cannula and then administer first I will talk about how do we place an IV cannula, intravenous cannula, and then how is the drug administered using this cannula. So we require a drip set, then tubings, then the syringes, needles, tourniquet, aseptic 2x2 gauze is required, then the spirit, adhesive tape, and the drugs that are required or necessary to inject to the patients are the basic requirements. So this is a tourniquet. I will show you the hands-on experience. Then I will show you how a tourniquet, tubing, and a syringe and all are placed, and how do we set the table ready before giving the IV, or the tray ready before giving the IV, putting the IV cannulation. So each IV cannula has a different color coding. This color coding mainly depends upon what is the amount of the drug or the size of the needle or the gauze of the needle. So it is measured in different gauzes. So every gauze has been given a different color coding. Like example, yellow coding is mainly 24 gauze needle, whereas orange color is 14 gauze needle. So depending upon the age of the patient and what is the condition of the patient and what is the purpose of administration and how much volume do we have to give the intravenous injection as one dose or multiple dose. Based on all these different settings, we can choose the IV cannula depending upon the cause. So now let's come to the procedure, how an IV cannula is placed and then the drug is administered. First, we need to check the patient's details of the patient, what is the patient's condition, what are the drugs that has to be given to the patient, and we need to ask the patient details, whether is he allergic to any drugs, has he taken IV drugs before, or is he allergic to any drugs. And then we need to explain the procedure and its beneficial and its benefits and complication. Every patient will be apprehensive when you say that you are going to give the drug through intravenous, or when you say that you are going to put an IV cannula. First, you have to tell the patient that it is a simple procedure, and then you have to calm the patient, explain the benefits and how you are going to do it. And then after explaining the benefits and the complications, then you have to perform the hand hygiene. You have to wash your hands properly and then load the injection syringe or whatever the drug that has to be given has to be loaded prior only, and it has to be kept. Then loosen the needle sheath and it has to be kept, but you should not remove it totally. You should loosen it and it should be kept aside. Then after this, we have to choose the largest vein. So depending upon the patient's condition, as I told you, you have to see which is the vein that is clearly visible and which is easier for you to put an IV cannulation. Choose the vein and avoid the sites that is either unhealthy, or if it is inflamed, or if it is scarred, or it has moles, it will be difficult for you to administer. Choose a proper site. And then in case of children, so it is desirable to anesthetize the site using a local anesthetic creams. If it is available, you can use an anesthetic cream that has to be applied at least minimum 1 hour before the injection or before putting an IV cannula. Then after this, first you need to tie a tourniquet above the site of the injection area so as to make the veins more prominent and more visible. Then you clean the area with alcohol or povidone iodine sponge from inside out in a circular manner. And then you have to take this proper aseptic measures. With a non-dominant hand, stretch the skin lightly in order to steady the vein. And then now with your dominant hand, what you can do is, you can discard the needle sheath, insert the needle then at a 30-degree angle into the skin surface with the bevel facing upwards. The bevel should reach at least 5 mm to 6 mm into the vein. And then you have to check for, once the blood starts black flowing into the sheath, then remove the tourniquet and then inject the drug at a particular recommended. So always check for the black flow of the blood at the end so as to ensure that all the drug has reached into the vein completely. Now gently withdraw the needle and apply the pressure on the site with the sterile gauze pad for at least 3 minutes. So better than explaining here, I will go to the IV model with the help of the mannequin. I will explain you how to secure an IV line and then how to give the drugs. So as I told you, some of the complications that you can encounter while giving the drugs through intravenous route, it can result in a hematoma formation if you puncture the vein. or it can result in thrombophlebitis. If you do not follow the aseptic precautions properly, it can result in the inflammation of the veins, or if there is extra vessation. So if you puncture the vein and the drug enters into the surrounding tissue, it can cause extra vessation and cause complications. And local infections can also be there, because of which, and in the rare, some of the rare complications is air embolism. This is one of the complications associated with, if while putting an IV drip set, if extra amount of the air enters into the IV cannula, it can result in air embolism. And inadvertent, instead of giving into the vein, if you inject the drug into the artery, then again it can cause inadvertent arterial injection, can cause gangrene like conditions. So you need to be very careful while giving the drugs, or while giving the medications, or any administering fluids, or even for IV. Intravenous route is not only used for giving the drugs, it's also used for collecting the blood sample also. So following the aseptic precautions while using an intravenous route is very crucial. So let's see what are this is about the brief introduction about the intravenous route of drug administration. Now we'll go to the mannequin and see what are the step-by-step guide to put and secure an IV line and give the drugs through the IV route. Thank you. Yeah, very good morning. So this is the mannequin where we are using it for giving the drugs through the intravenous route. So this is an IV model. Basically, it has a hand, mannequin has a hand with the veins visible on it. So as I told you, first for putting an IV cannulation, what are the equipments that are required? So this is the IV drip set, which you are going to connect it to the IV cannula. And this is the tourniquet which you are going to tie to the patient hand at a proximal site, so as to make the vein visible, so that you can easily administer the cannula and secure an IV line in the patient. Then to take the cotton is required to clean the cotton swab to clean the area with the spirit. And this is an IV cannula which we are going to place here. And as I told you, if you are going to administer the drugs, that has to be loaded in the syringe and it has to be kept ready. So you have to just loosen the cap and you have to just place it, so that it will be helpful for you to administer the drugs. Then, yeah, gloves have to be kept ready. So this is how the working station of an IV model has to be kept ready before giving the drugs through intravenous route. So let's see what are the step-by-steps steps involved in securing an IV line. So before proceeding, first as I told you, you need to ask the patient details. Okay, so what drugs he is receiving, what is the age of the patient, what condition, why is he admitted. You have to see the patient details and what is the dose of the drug that you are going to give. So that has to be seen, and you should ask for history of allergy. It is one of the important things before giving drugs through intravenous route, because even a minute dose of the drug can cause anaphylactic reaction. And the anaphylactic reaction can range anywhere from a simple rash, or it can result in even severe anaphylactic reaction resulting in death. So asking for history of allergy is very, very important. And sometimes you need to always have an emergency tray ready if you are giving a large amount of drugs, or drugs giving through as an infusion. If you are giving, then if the drugs which are known to cause allergic reactions, like in case of iron injections, where they are known to cause anaphylactic reactions. So such cases, an emergency tray has to be kept ready, which contains emergency drugs like injection adrenaline or antihistaminics are kept ready, or even corticosteroids, hydrocortisone injection are kept ready, so that you can save the patient's life. So after checking all the details of the patient, you need to wash your hands. First introduce yourself and briefly explain the procedure to the patient. Then you need to wash the hands and select the appropriate site. So while talking to patient only and explaining him the procedure briefly, you have to see which vein you are going to see and which vein you are going to select. So every patient veins are going to be, every patient is going to be a different vein. So you have to select what is the vein that is clearly visible. You have to palpate for the vein, and then the most prominent visible vein has to be selected. Then after this, you have to tie a tourniquet. So by tying the tourniquet, the vein gets engorged so that it becomes more prominent and you can place the IV cannula securely. So I am going to tie the tourniquet here, proximal to this area. So I am going to here, I have selected a vein in the forearm and I am tying the tourniquet proximal to that area. You have to remember that, so that by tying proximally, this vein gets distended. So this vein is clearly visible now. So after tying the tourniquet, you have to clear the site with alcohol. So this is the vein which I have selected. I don't know whether it is visible. Yeah. So this is the vein that is selected. So in a inside circular manner, you are going to clean this site with the spirit using a sponge. Then after cleaning it, you need to put on the gloves. After putting the gloves, you have to remove the cannula. So I told you every cannula is again color coded and has different gauze. So based on patient's age and different conditions, you choose the cannula, appropriate cannula before only, and then you place it. Then you remove the cannula from its cover. Yeah, this is how the cannula looks like. So after this the cover needs to be removed. And then with the bevel upwards, the bevel of the needle upwards, you need to progress slowly into the selected and the engorged vein which you have selected. Insert the needle, bevel upwards, and the angle of insertion for inserting an IV cannula, as I told you, is 25 to 30 degree angle. So once we insert it into the vein, slowly we need to proceed. Yeah. So once we proceed for 5 mm to 6 mm into the vein, as we can see here, there is a backflow of the blood in the cannula here. So once we see that there is a backflow of the blood into this, that confirms that we are in the vein. That is a very important step. So once that is there, then the needle has to be removed from this. So you have to apply the pressure onto this, and the needle has to be removed. So now this is for the placing the IV cannula. If you want to administer the drugs, then what has to be done is, after placing this, we can insert the needle into the cannula, when whatever is the amount of the drug that has to be given can be administered by flushing or injecting the drug into the cannula. So the first thing was, first we placed the IV cannula into the vein, and then we gave the drug, the amount of the drug which we had planned, we have injected the drug into the vein. Once this is done, then again apply the pressure. Then this can be closed. So this IV cannula which has been placed, so this can be secured with the help of an adhesive tape, and it can be used for multiple drug administration. Either you can give repeated bolus injections, or you can connect it. If it is in the form of infusion, you can connect it to an infusion set as well. So these are the steps which are followed for putting an IV cannula, or by giving the drugs through intravenous route of drug administration. So after this, the dressing has to be applied. So we are securing it by applying an dressing. Yeah, these are the steps. Any doubts are there? Any doubts? Thank you.
So, yeah, if you have any doubts, you can type it in the chat box or Q&A sessions. We can take up the questions. Then Dr. Netravati ma'am can take up the questions. Participants, if you have any doubts, you can also raise your hand. Anyone from the... Do you have any doubts? No? So shall we move to the next session? Yeah.
Okay. Here I thank you, Dr. Netravati Angadi ma'am. Thank you for a wonderful session. On, okay. On the optimizing intravenous drug administration. If anyone wants to ask the question, please post it in the chat box. If there are no questions, we are making arrangements for our next section. Give us a few minutes. Thank you.
It's my pleasure to introduce our next speaker for today's session, Dr. Soumya S., Associate Professor in the Department of Microbiology at Jawaharlal Nehru Medical College, Kahir, Belagavi. Ma'am has published 20 publications at national and international level, and also she has published 5 patents. She has been awarded with the Best Poster Presentation at National Conference APPI in 2018 and at JNMC Scientific Society Annual CME in 2019. Her areas of interest is on mycology and bacteriology. We are very fortunate to have you with us, ma'am.
A very good morning to everyone. Myself, Dr. Soumya S., Associate Professor in the Department of Microbiology, JN Medical College. I would like to first of all thank the APPI, all the organizing persons, as well as Dr. Harpreet Kaur for giving this opportunity to be the resource person for this event. And the topic for today's my presentation is hand hygiene, with the main aim of clean hands are safe hands. So hand hygiene is one of the most simplest and most effective way of preventing the spread of infections. Whether it is in the hospital setting, whether it is in our home or public places, proper hand hygiene can prevent and protect both individuals as well as the communities from most of the harmful pathogens. So what is a good hand hygiene? A good hand hygiene is nothing but regular hand washing with soap and water or by using any alcohol-based hand sanitizers, which is very crucial to prevent the germs and to stay healthy. So what is hand disinfection? It refers to hand wash, hand rubbing by using hand antiseptics, decontamination or degerming. So brief history, how this hand hygiene came into picture is the person called Ignaz Semmelweis. He is a Hungarian physician. He is known as the father of hand hygiene. Why? Because he was the first person in mid-90s to establish the importance of hand hygiene and its association in how we can prevent the infections. So a brief small story, how he came up with this idea is I thought was very interesting to share with you all. He used to work in a general hospital and he observed that there were two types of clinics. One is a midwife run clinic and other one was a hospital run clinic. He observed that the infections in a midwife run clinic had fewer deaths compared to the hospital run clinic. And retrograde, when he went and did the observations and his analysis, he found out that in doctor run clinics, the doctors as well as the medical students, they fail to follow the hand hygiene before examining the patients. After doing the cadaveric dissection, they directly went and observed the patients even without following the hand hygiene. So he made it mandatory a hand washing policy using chlorinated lime solution for doctors and medical students and saw that there was a drastic decrease in the mortality rate in these doctor-run clinics. In spite of proving this, he had a lot of resistance for this hand wash and all that. But ultimately, it was well accepted and till date, we all are following his footsteps. So why this hand hygiene is important? First, it prevents the spread of infection. May it be any bacteria, virus, or any other microbes. And it lowers the healthcare associated infections. And it also it also reduces the antibiotic resistance. When there is no infection, so no antibiotics. So no antibiotics, definitely the antibiotic resistance also decreases. So when do we use this hand wash? First, in daily life, before preparing the food, before eating or after using the restroom, after coughing, sneezing, or when we blow our nose, or whenever we are handling the garbage or touching animals, we're supposed to follow the hand hygiene. Very, very important is in healthcare settings. So WHO has given 5 moments of health hygiene. So first is before patient contact, before any antiseptic task, like how Dr. Netra told us before doing any IV injection or IV cannulation. Those are some of the steps. So then before body fluid exposure, after body fluid exposure, after the patient contact, and after touching the patient surroundings. So these are the 5 movements in healthcare settings where hand hygiene needs to be followed. But we all do hand wash. We all know about it. But what is the main mistake? Why we are doing it today? The main common mistakes what we do is we don't wash our hand for long enough. I'll tell you which one has to be done for how many minutes and all that. So main is we are not washing the hand long enough. Second, we are missing the key areas like our thumb, the fingertips and the wrist, which is a very, very important part which carries the infection. And we are using shared towels. We are supposed to use a personal towel or disposable handkerchiefs. Then mainly we are relying solely on hand sanitizers when our hands are visibly dirty. Whenever there is a visibly dirty hand, we're supposed to do hand wash. I'll tell you the difference about this.
So there are three main types of hand hygiene. One is hand rub, hand wash, and hand scrub. So we'll see what are these. First is hand rub. It is a very quick, waterless hand hygiene method where we are using alcohol-based solution. And this alcohol-based solution should contain at least 60% of alcohol in that. And when do we use this? When our hands do not have any visibly soiled dirt, in clinical settings, between the patient's interaction, and for routine disinfection in public places. So post-COVID, you all have come across these sanitizers which are kept at every shops or any theaters and all. They all are for hand rub, that is made up of alcohol-based solutions. What are the advantage of this method? It's a very convenient and quick and effective against most of the bacteria and viruses. But it has got some limitations, like it cannot act against the spore forming organisms, and it is ineffective when our hands are visibly dirty and is greasy and dirty. So what are the steps? I'll demonstrate it for you all after the end of this session. So the technique is, first we take ample amount of sanitizer in both the hands and rub palm to palm, back of the hands, between the fingers, nails, and continue to rub till the sanitizer or the hand wash completely dries. So it takes around 20 to 30 minutes. So this duration is very important. You're supposed to do it for 20 to 30 seconds to be effective hand rub. So next is hand wash. So hand wash is the process where we are using soap and water. This is what we do on regular basis in a house. So that is called as hand wash, when our hands are visibly dirty, to remove the dirt, grease. So, or after when we are using any restroom, and before eating or handling the food, and after handling any body fluids, we are supposed to do hand wash. What are the advantages? It removes the visible dirt and pathogens, as well as it is active against the spore forming organisms, unlike the hand rub, which was not active. And limitations is, yes, we require soap and water and towels, and it requires more duration of time compared to the hand rub. The technique is same for hand wash and hand rub, but thing is, it has to be done minimum for 20 minutes up to 1 minute. So next is hand scrub. So it is an aseptic cleaning of hands and forearm. So all this what we told was till wrist, but in this hand scrub, it is the full till the forearm we are doing the procedure of hand hygiene. This procedure is usually followed before any surgical or interventional procedures, and we use betadine wash preferably for this hand scrub. And main advantage is it reduces the resident and the transient flora which is there on the skin, and it has a prolonged antimicrobial activity. But the limitation is it is time consuming and requires sterile conditions and specific antiseptic products. As I told you, it requires a betadine wash, which is commonly used. So the technique remains same again, but the main difference is we are washing the whole of the forearm, and it requires around 2 to 6 minutes of time for an effective hand scrub. So the difference I have already mentioned in the lecture as I was giving you. This is a overall picture compilation of the difference between hand rub, hand wash, and hand scrub. So the takeaway message is clean hands can save lives. Whether we are a healthcare provider or a member of a public, hand hygiene is a simple act which can bring a very big impact in our lives. So one more thing is there is a day called as a World Hand Hygiene Day, which is celebrated annually on 5th May every year. It was started by WHO in 2009 by a campaigning called the Save Lives, Clean Your Hands. And every year it comes up with a new theme, and theme for 2025 is it might be gloves, it's always hand hygiene. So this is the motive for this year 2025 World Hand Hygiene Day. Thank you. I'll demonstrate you the hand rub, how it is done now.
So welcome you all to the live demonstration. Before doing any hand hygiene, first and foremost, very important is remove all your accessories. So the finger rings, so welcome to the live demonstration. The first and foremost important thing is you're supposed to remove all the accessories from your hands. The finger rings, the watch if you're wearing, and any bracelet or bangles if you're wearing, you're supposed to remove it. Then take ample amount of sanitizer in the hand, either 1 or 2 pumps. Then rub palm to palm. Then interlacing of the fingers. Then back of the fingers and the palm, both the hands. The important one, as I told you, the thumb, the the palm, and then the fingertips. The last, one more important part which I told you was the wrist. So this completes the hand rub. Hand rub is till the sanitizer dries off from my fingers. It will be approximately around 20 seconds. So this is the hand rub. For hand wash, it is similarly done with soap and water. For hand scrub, we are supposed to do till the forearm completely. So that is called as hand scrub. So this is the main difference between hand rub, hand wash and hand scrub. Whatever I did now was hand rub. Thank you.
Thank you so much, Dr. Soumyas Madam, for taking time to be with us today. Your insight will be invaluable to our learning. Participants, do you have any questions? Please drop it in chat box. Participants, do you have any questions? Please drop it in chat box. Okay, thank you. On behalf of everyone, I would like to thank you, Madam, for your sharing your knowledge with us. Give us few minutes to change the setup. Thank you.
Good afternoon, everyone. Let's welcome our next speaker, Dr. Sunil Vernekar, Professor of Physiology at Kahar Jawaharlal Medical College. He is also the member of WHO Collaborating Centers for Research in Maternal and Prenatal Health, and he serves as the Senior Research Officer, the Global Network for Women's and Children's Health Research, and he's project coordinator for several critical studies, including WHO Action Trials in India sites, Codwork study, the Life Study India sites, and WHO Labor Care Guide for cesarean section, and he's the facility director for WHO Champion Trials at Belgavi site. Please join me welcoming Dr. Sunil Vernekar to present Helping Babies Breathe.
Okay, good afternoon. Thanks for the introduction. Today I will be demonstrating and talking a little bit background about the neonatal resuscitation. So it is basically what I am talking here is about the fundamental resuscitation skills, not the advanced resuscitation skills. So this is to target the population, target the birth providers or the providers who are there at the delivery time. So it does mean that there should be a skilled person who can resuscitate at the labor or at the time of the delivery. So that is a basic target of this program. So this is called as Helping Babies Breathe program, or you can call it as curriculum also. Just to tell a background about why this was developed and how this was developed and how it has been assessed. So basically talking about the neonatal mortality. So the global neonatal mortality has definitely come down. Maybe around 15 years ago it was 4 million deaths, neonatal deaths per year, and now at present, by the last year, it has come down to 2.3 million globally, and among these neonatal deaths, 30% is contributed by India alone. So South Asian countries and India. So India alone contributes about 30%. So we have to tackle, this is a big menace, and we are trying to improve this rate by decreasing it, but still there is a lot of things to do. So a small effort in this reduction is to do the neonatal resuscitation program, or this is a teaching curriculum. So this was developed by the American Academy of Pediatricians with collaboration with the Global Alliance, which includes the funds from USAID, the American Academy of Pediatricians, the Lardale Foundation itself. Lardale manufactures this mannequin, so they have funded this program and they are a part of this Global Alliance. And apart from this saving babies' lives, so there is another organization, and of course the NICHD, National Institute of Child Health and Development, or which is a branch of NIH. So all of them combined to put an effort and develop a program which can increase the basic fundamental neonatal resuscitation skills among the primary healthcare workers or the providers. So this is the background of it, and actually seeing the scenario in the high income countries and the low income countries, there is a lot of drift here. You can say there are hospitals in high income countries where we have a capacity of 400 to 500 beds for the neonatal admissions, but we don't even see 1 or 2 admissions per day. And the contrast is in our country where we have admissions which can go around 40 or 50 per day, and we have only some 10 neonatal beds. So in each bed we will be having some 2 to 3 neonates. So that is the condition, that is the scenario when you see in the developing countries and the developed countries. So even if you have facilities also, you may not be able to provide it to all the required patients or the babies. So what this program tries to do is that it tries to improve the neonatal skills, resuscitation skills of the providers itself who are conducting the delivery. There is no need to go and call the pediatrician for each and every case. So they have ample of time to tackle the cases which are really complicated, which cannot be handled by a basic medical doctor or a nurse. So this resuscitation program or a curriculum, as I told, it is targeting all the providers who are present at birth. It can be a nurse, it can be a midwife, it can be a ANM, it can be a general medical doctor, or it can be a pediatrician or any physicians. Anyone who is there in the labor room, who is conducting the delivery or who is helping the person to conduct the delivery. So there are, we have some equipments here for this training program. So this is basically a training program. Actually, it requires 1.5 days to train a person and certify for this Helping Babies Breathe program. And this is present in the website, Helping Babies Breathe website, which is sponsored and maintained by the American Academy of Pediatricians. And we have some equipments which we can carry in a bag for the training purpose. So it includes a simulator, a neonatal we can call it as, or a mannequin. And then we have other equipments like there is a stethoscope, a dummy stethoscope, suction device, a bag and mask. There are 2 masks of different sizes. There is a bag which is working bag, and then a simulator which can simulate the cry of the baby, and then a cap for covering the baby's head, and then we have 2 towels. This is basically for training how to use all these equipments, and then of course gloves. And as Madam had told about the sterilization, I mean washing the hands or rubbing it with the solution. Okay, so all this, it involves all these things, along with a main thing what is there for the training purpose. This is called as the action plan. So you can see here, action plan has a different, has an algorithm which is very simple. It is not a full-blown NRP procedure. It includes only the fundamental steps. So here, as I told you, the main aim is to start from the preparation of birth. So you can see the beginning of this, it is a preparation of birth. I don't know if you are able to see this. So here it starts the preparation for the birth. Yes, now it is better seen. So it starts, this algorithm starts from the preparation of birth, where there are at least, it recommends presence of 2 people along with the person who is conducting the delivery. There should be another helper. He may be a specialist or he may be a nurse, or at last if nobody is there, you can take the help of the companion, birth companion, who has come with the mother who is come for the delivery. The relative of that mother can be taken for help. So there is a need for some other person to get some help. There may be some help needed to call the ambulance, to call the pediatrician, or something in emergency purpose which is needed. So for that reason, it is recommended that there should be another person who works as a helper for you. So that is the preparation for the birth. Along with that, you need to prepare the table for the delivery. So someone informs you that a delivery is going to occur, and someone calls you and informs you. So the person who is going to conduct the delivery, he is going to prepare the table for the delivery. So all the equipments, whatever are required for the delivery, they will be prepared. Along with that, there is also the preparation of preparation for resuscitation. A table, a small table with a hard surface is kept ready with all the clean, with the table cleaned or sterilized, and then some equipments which are required for resuscitation, like the bag and mask, the knots, the ties, the scissors which is required to cut the cord, and then the 2 towels which are used to dry and then cover the baby. So these are some of the basic things which are required for resuscitation purpose. So these all things will be kept ready. So before making this ready, we need to talk to the helper. Now I will take Dr. Kumaran as my helper to just demonstration purpose. So Kumar, can you come here? So I will discuss with him the strategy, or rather we will come here. So Kumar, we are going to get, a woman is going to come here for delivery. So we will see that all the things are prepared for this delivery now. What I require here is the delivery table is there, so it is kept clean also. You can tell the nurse to keep it ready, and then we may require, if the delivery occurs and if the baby doesn't breathe, we may require for emergency resuscitation some equipments which are there, like the towel, the bag and mask, then the suction device and all. We will keep it ready. But before touching it, we will both wash our hands. So the washing hands has been very nicely and explained by Dr. Soumya. So I will not go to the details of it. It's the same procedure. Either you can use rub or you can wash it with the running tap water. Use the soap and wash it with the running tap water with all the steps, both the hands washed, and then don't touch anything else. You can wear the gloves, okay, and then use the sterilized equipments which are meant for resuscitation. So what all we will give? So I have washed my hands and I have dried it, and then I have worn the gloves also. So like me, Dr. Kumar also he has washed his hands and he is ready now. So now we will see that all these equipments are kept ready. So there is a bag and mask. So we have different size mask here and with the bag. So I will see whether it fits in, whether it works properly. So this is working properly. We have the suction device which also is working properly. So I will test it whether it is working by pressing and seeing the suction force. And then a stethoscope is there, and we have 2 sterile towels, and we have a cap for the covering the head of the baby so that it doesn't have hypothermia. So these are all the preparation for birth. So why we are emphasizing on this preparation here is there are 3 main causes of there are multiple causes of causes for neonatal mortality. Among them, 3 are most important, and they are first goes to the preterm delivery, preterm birth, and the second is birth asphyxia, and the third, or maybe they may interchange, the sepsis. So infection, preterm birth, and birth asphyxia. So these are the 3 main causes of neonatal mortality. Along with them, there are other causes which do not contribute as much as these. So they contribute to around 80% of the causes of the neonatal deaths. So here we are trying to tackle all of this. Maybe we cannot tackle the preterm birth, but we can provide the essential newborn care for the preterm born baby. And of course, we can tackle the infection by washing our hands, by using the sterilized equipments. So that is tackled to some extent. And then of course, we are talking the most important part here is the resuscitation part, where we are going to tackle the birth asphyxia. So we are going to discuss and we are going to show and demonstrate the basic resuscitation skills what a provider needs to have, okay, before any pediatrician or any tertiary care provider comes there, or we need to take the baby to the tertiary care hospital. So this is basically targeted for the low resource facilities like primary health care centers or peripheral unit where the resources may be less, okay, but the deliveries may be conducted, or a NICU may not be available at that hospital. So in these kind of settings, this is most useful. So as this algorithm goes, first we will prepare the table or all the room for the delivery, and also for the resuscitation if it is required in emergency. And also we will see that the room is kept warm by closing all the windows and switching off the fans so that the baby doesn't suffer from hypothermia. And we will also ensure that there is sufficient number of towels, sterile towels to cover the baby. And then, so these are the preparations what have to be done. And it goes along with this training program goes, and it advises the birth attendant to ask questions to himself and answer himself along the delivery and along the resuscitation skills. So that is the main purpose of it. So even the action plan says so, that once the baby has taken birth, what we are going to do if the birth has occurred, the baby is in our hand, and now what we will do, the first and foremost thing is not to see whether the baby is crying or not. My first and foremost thing, just here hold it, and now he is handing over the baby to me. So what I will do, I will put these sterile towels on the mother's abdomen. It's better to be delivering the baby onto the mother's abdomen. So that is the recommended position. Instead of delivering it onto the side and keeping the baby onto the side of the mother, we have to rather keep it on the mother's abdomen, because this will tackle the hypothermia problems and all. So once I have taken it, I will put these 2 towels are placed on the mother's abdomen. Think that it is placed on the mother's abdomen. We will place this baby on the mother's abdomen with the cord intact, And then first and foremost thing what I will do is not to do any assessment here. Just start drying this baby from the head to the toes. For every part of it, I will try to dry it thoroughly, not mopping, not just mopping like this. I will rub it. I will rub it so that all the wet part will go away. And also this rubbing gives a kind of stimulation to the baby. So I will see that every part of the baby is rubbed and dried. And then what I will do, I will remove this wet cloth and keep it aside. And now I have another dry cloth here. I will place this baby on the dry cloth. I will try to assess it. I will ask the question to myself whether the baby is crying or breathing. So now good cry means that the baby is able to breathe. So I will just assess if it is breathing or not. So if it is breathing, then there is a routine care. This chart tells us about the routine care. So routine care means you are going to place it on the, you will cut the cord about 2 finger breadths, you will tie one knot, and for 5 finger breadths from the abdomen, you will tie another knot, and then in between you will cut it with the scissors, sterile scissors or a sterile blade, and then place it on the mother's abdomen in such a way that it will give skin to skin contact to the mother, and then cover it with a dry cloth, and then assess it whether it is able to breathe properly, whether the chest movements are proper, without any grunting, without any gasping. So it should be breathing quietly. So that is more important for us. And once we are assured of the breathing, normal breathing, we tell the mother or we advise the mother to handle the baby with the skin to skin contact and try to start the breastfeeding as early as possible within 1 hour. So once and then hourly feeds can be given, and we should also alert the mother that there can be breathing problems to the baby if at all. And if at all she sees that the baby takes a long breath and stops in between or keeps on irregular breaths, a deep sigh and then stop. So all these are kind of irregular breaths. So if she sees something in that baby, she should be coming and telling the doctor or alerting the doctor that the baby is not breathing properly. So they will take care of it. So they will tell us and we will take care of it. So this is the advice what we give for a normally breathing baby. Now the other scenario that we have dried the baby, and we have placed it on the mother's abdomen. So drying part is done. But when I ask the question to myself whether the baby is breathing or crying, I am not able to see the movements of the chest and nor the cry. So now it alerts me that there is some breathing problem to this. So now what I will do, I will take a suction device. First thing is take a suction device, remove the secretions from the mouth and the 2 nostrils. Do it as fast as possible because we have to finish everything within 30 seconds and start with the ventilation. So the time is more important here. So this whole chart tells us that all the breathing things, all whatever efforts we have to do, it should be within 1 minute. So that is called as golden minute. This is to ensure that there doesn't be any neurodevelopmental abnormality in the baby. Even if we save the baby after 2 minutes or 3 minutes, if we start the ventilation, it may have some neurons may undergo ischemic damage, and then there may be a permanent abnormality or cerebral palsy in that baby. So we don't want to have a limp baby all throughout the life. If we are saving, we will try to save a normal baby. So that is most important. So that's why the importance of golden minute ventilation. So all the things what we are doing, we need not waste more time in each step. We have to try to do it as quickly as possible. So even suction also, we will do it twice or thrice in each nostril and in each and the mouth. So once we are thorough that we are confirmed that there is no secretions, then I will again assess. After clearing the secretions, I will assess whether the baby is breathing or not. So if it is still not breathing, what I will do is the next step is go for stimulation procedure. Stimulation. So what we will do for stimulation? We will just rub the back thrice or 4 times. And not waste more time, not keep on rubbing like this. The correct procedure is rub the back firmly and fast for 4 times and then try to assess again whether the baby is breathing or not. If still it is not breathing, then what we will do? We will immediately take the baby for ventilation. So these all procedures should be finished within 30 seconds. So that is most important. That's why this training program. So again, like the cord cutting procedure, we will do it. And we will cut the cord, and then what we will do, we will take the baby from the mother's abdomen to a hard surface. We have arranged already we have arranged a table for resuscitation purpose, we'll take the baby there. And what is the position of the baby? The position of the baby is the head of the baby should come towards our side, or I should be facing the head of the baby. So this is the correct position to do a proper effective neonatal resuscitation or effective bag and mask ventilation. So what I will see, I will check this mask whether it fits to this baby. So usually there are two size masks. One is meant for the preterm baby and one is meant for the standard size, which is meant for the normal birth weight or normal term baby. So here it looks like a term baby. And now what I will see, I have already cleared the secretions. I will immediately go for bag and mask ventilation. So here, how do we place this mask? It should be placed on the rim of this mask should be placed on the tip of the chin. So it is placed there, and then we cover the nose and the mouth. So it should be covering the mouth and the nose properly. There should be no leakage. And then see that the hand, the two fingers should be in the shape of C. It should be placed on the stem of this mask and put pressure here with these two fingers. With the three fingers, try to extend the neck. This is below the jaw, these three fingers. And the two fingers, the thumb and the index finger, will be on the mask. So I will place it here and then pull the jaw, lower part of the jaw, and extend the neck so that the airway is free. And then start breathing, start ventilating slowly. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Here I am able to see when I am doing this ventilation, my eyes will be on the chest of the baby to see that there is normal movement of the chest. So our ventilation should be such that it should be the chest should be moving quietly and freely. It should be as if the baby is breathing on itself. So it should not be very harsh nor too less. There should be movements, but it should not be harsh. Harsh we can call it as moving, pressing it very hard. So if you press it very hard, the sound will be there, hissing sound, and it indicates that it is causing damage to the lungs of the baby. You are not providing the ventilation, you are even harming the baby's lungs with the excessive pressure. So adequate pressure is required. So adequate pressure can be given by pressing the bag with only three fingers, one thumb and two the index and the middle finger. Only with these three fingers you are going to press it, and see that the two fingers don't touch to each other. The thumb and the middle finger and the index finger don't touch to each other. They should be midway. So only that much of pressure should be put. And also I was uttering breathe 2, 3. So this is to ensure that my ventilation rate is around 40. Around 40. So that is the rate what we need to ventilate the baby. It should not be too less than 30, nor too high, more than 60 and all. We cannot enthusiastically go on pumping very hard, saying that I am trying to save the baby. It will go in a reverse way. It will harm the baby. So that's why we have to see that we are maintaining the adequate pressure, we are maintaining the adequate rate, and also we are seeing that there is no leakage from the mask. We may be doing everything, but if the air is leaking from the mask, if we are not put it properly to the mouth and the nose, covering the mouth and the nose, it may not be an effective ventilation. It may go in waste. We are trying to do everything, but the air may not be going to the lungs of the baby. So we have to see that these three things are proper. The rate should be proper, the bagging should not be harsh, it should be adequate ventilation, and there should be no leakage. So these three things are important for us. So with that, we will doing the ventilation like this. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. If now the baby has started breathing with my ventilation, if the baby has started breathing, I will come to know it. How I will come to know it? Now just Dr. Kumar will demonstrate it. So when I am doing this breathe 2, 3, in between I am seeing that there is some movement by the chest. Without my ventilation, there is movement in between my ventilations. So that means that the baby is trying to breathe. So when the baby is trying to breathe, I cannot put more pressure. I have to leave some time for the baby to breathe. So what I will do, I will try to decrease the rates of my ventilation. So breathe 2, 3, 4. Breathe 2, 3, 4, 5. Breathe 2, 3, 4, 5, 6. breathe 2, 3, 4, 5, 6, 7. So I'm allowing some time for it to start breathing on its own. And once once I am confirmed that the baby is breathing on its own without any grunting or without any abnormal breaths, then I will observe it for some time, and then again the routine care, the handing it over to the mother, or advising the mother to breastfeed. So now in another case, if at all think that the baby has not started breathing and I am continuing the ventilation, so we are not supposed to stop the ventilation in between and ask and advise and discuss. So our ventilation should go on, it should not stop. Once we have started it within 1 minute, it should continue. And at the same time, I ask my help of my assistant. I will tell him to call for the pediatrician and call for the ambulance and be ready, so that we will transfer this baby through the ambulance to the tertiary care hospital, because it is not recovering with our basic care. So it may need intubation, or it may need other cardiac support or respiratory support or ventilation as such, or it may need oxygen also, which is not available here. So I will ask him to do that. Until then, I will continue this ventilation. I will continue the ventilation. In between, sometimes what may happen is, just press it. So sometimes what happens is, I am trying to do the ventilation, but there is no chest rise. So if I see that, then what I will do, I come to know that my ventilation is not becoming effective. So there is some problem in the ventilation. So what I will do, I will reassess the position, the other features, what is there for the ventilation. So what I will do, first reposition the baby, that is extend the neck, and then see whether the secretions are there which are obstructing the passage of air. So if it is there, I will just clean the airway and reposition the head, and see that the mouth is wide open, because the babies try to close it usually. So we open the mouth wide and try to hold it, and then reapply the mask. Also check whether the mask is fit properly to the back, and then apply it, and then again start the ventilation. The first 2-3 ventilations should be a bit harder, so that is, it should make that sound. So this is not continued long. This is just for first 2-3 harsh breaths, because we want to clear the air secretions which are there in the midway, in the bronchi also. So once that is cleared, the other ventilation should be again quiet, so it should support the baby's respiration. So this will continue till the baby starts breathing on its own, or till the pediatrician arrives, or we take it on the ambulance till we reach the hospital. So we are not going to stop it till we hand it over for the advanced care. So this is all the basic resuscitation skills what we need. So this is about the training program. So these are all the steps which we wanted to emphasize. So again, to tell, this resuscitation program includes the basic skills, the fundamental skills, taking care of the baby, taking care of the environment, where to deliver and how to do the resuscitation, keeping the equipment ready, then assessing the baby by asking some questions to yourself. Once we dry the baby, remove the wet cloth, then try to assess whether the baby is crying or not. If not crying, go for the second step, that is clear the secretions from the mouth. If it is cleared, ask yourself again whether the baby is breathing. If it is still not breathing, then go for the stimulation. Stimulation, 2 to 3 rubbing on the back. Don't waste more time. Now if it is still not breathing on its own, by all these steps, these are the basic resuscitation steps. If it is not recovering by this, then cut the cord and take it immediately to a corner where you can, on a hard surface table, and then start the ventilation. So already you had kept everything ready, so that you are not going to waste time, because we are more worried about this golden minute. Everything should occur and we should ventilate, or the baby should breathe within 1 minute. That is our motto. So these are the ventilation skills, and till the baby starts breathing on its own, we are going to continue, not stopping in between. But if there is no chest rise, then we will stop and reassess whether there are secretions, whether the position is correct, whether the mask is applied properly to the back. All these things we will assess, and then again immediately start ventilating till it starts breathing on its own. So this is the basic resuscitation skills. So this doesn't include the advanced care. So this is the HBB curriculum which is used for training. So we had done a study in 2009. The American Academy of Pediatricians developed this program. This became a curriculum actually, and now it is followed in many of the countries worldwide, especially in the peripheral centers, and also it is being taught in medical colleges in many of the institutes, including our institute. It is scheduled in the pediatrics teaching program, is HPB curriculum. Do they ask any questions?
So, yeah. Audience, if you have any question, you can put in Q&A box or you can raise your hand so we can unmute you and you can directly ask the questions. Anyone is having any question? Okay.
Thank you, sir. Thank you for the wonderful demonstration session. Now I am going to handle the mic to the Dr. Sophia for the vote of
Good afternoon, ladies and gentlemen. A very good afternoon. I am Dr. Kopi Anju, PG1 Physiology. It gives me an immense pleasure to deliver the vote of thanks for this wonderful event. I would like to thank all the dignitaries assembled here, online and offline. I would like to thank my deepest gratitude to all the teachers, resource person who showed us the procedures in a very easy and simple way. A special thanks to Dr. Atik sir, Dr. Netravati ma'am, Dr. Soumya ma'am, Dr. Sunil sir, all the staff members of Skill Lab. Without you guys, it would not have been possible. I would also like to thank to IT department. Your behind the scene efforts have ensured the smooth running of this program. At last but not the least, all the faculty members and the colleagues, thank you for your presence and patience and make this workshop really very successful. As you all know that Epicon 2025 will be hosted at JNMC Belgaum. So we are looking forward to host you personally and see you in October 2025. Once again, thank you. All those who have attended online and offline, thank you very much.
Thank you everyone and see you next month for the next session. Yeah, thank you so much. We will end this meeting.